do not know the ins and outs about dialysis and all the drugs and autoimmune or immune modulating drugs that exist. But I do have an interest in our pregnancy care, like you so rightfully said. So I'm trying to approach this talk a bit from an obstetric point of view. That being said, all the difficult questions, I wish I had brought my physician friends and my obstetric medicine friends to answer all the difficult questions at the end. So I think when we talk about any medical condition or any organ system involved in pregnancy, we should always, before we get into the pathology, we should talk about its physiology, because pregnancy is a test for a woman's body. It is a test for all organ systems, the respiratory system, GIT, the heart, and then obviously also the renal system. Everything gets tested. And it's often pregnancy that brings to light an underlying problem that we didn't know was there before, because the body needs to adapt to this change, to this growing pregnancy, to this baby or multiple babies during a woman's reproductive life. So just a little bit briefly, what are the physiological renal changes in pregnancy? Because what is normal outside of pregnancy is not always normal in pregnancy and vice versa. So one of the first things, or one of the things that changes in pregnancy, is that we get a dilatation of the urinary collecting system. So different hypotheses. I've based a lot of the physiological changes here from the obstetric medicine textbook written by Catherine Nelson-Piercy. So it also states that the hypothesis is that firstly, there's a smooth muscle relaxation in the ureters induced by progesterone that could contribute to the dilatation of the kidney, the collecting system. Could also be outright mechanical compression of the ureters by the enlarging uterus or the iliac vessels. It seems to be more pronounced on the right due to the way the uterus is turned. And we can get this sort of physiological hydronephrosis in pregnancy and is considered not worrying up to 2 centimeters, which I think is already quite large. To know is that, and this is why I think the hypothesis is there, that it's not just merely a mechanical compression. The moment a woman has delivered, it doesn't immediately subside. It might get a bit better, but we are not worried if 6 weeks post-delivery, even up to 2-3 months post-delivery, it takes a bit of time for that collecting system to go back to normal. There's hormonal changes and so forth that need to be withdrawn post-pregnancy. So don't be surprised if just relieving the compression of the ureters doesn't immediately resolve the hydronephrosis. Then in terms of our renal plasma flow increases during pregnancy with a maximum of a 60 to 80% increase, in the second trimester, then reduces a bit again, but at term is still about 50, still has a 50% increase of baseline. GFR increases, but shouldn't actually be used in pregnancies, because the formulas used to calculate an estimated GFR depend on a steady state of creatinine balance, but that changes with gestational age in pregnancy, which I'll show you just now. The creatinine clearance increases. We have an increased protein excretion, so hence different cutoffs in pregnancy versus outside of pregnancy. So always look at the units in which your lab reports. So we talk about either a 24-hour urine excretion, protein excretion in the urine, where we will quantify either in milligrams, where under 300 milligrams or less than 0.3 grams per 24 hours is still considered physiological in pregnancy. We also more and more work with the urine protein creatinine ratio, which is very much acceptable and actually recommended in the major guidelines talking about kidney disease, either acute or chronic in pregnancy, is the use of protein creatinine ratios. So there the unit we would use, or the cutoff we would use, is 30 milligrams per millimole or 0.03 grams per millimole. Know that these PCRs are, like I said, very much so validated for use. You can use them. 24-hour urine collections are an expensive process. Women often need to be hospitalized. They're often not done correctly because you want the total amount of urine that is produced in 24 hours. So if you want to do just briefly a 24-hour urine collection, a woman is supposed to empty her bladder before the time starts, because the urine that's in the bladder at that point is produced before your 24-hour cutoff. And then just before the 24 hours have passed, that's when the woman the last time pees in in her bottle, and that's your 24-hour collection. So it needs to be done correctly to be reliable. So we're more and more moving towards the use of protein creatinine ratios on just urine samples. And then we'll talk about this in a couple of slides a little bit more in depth, is that the creatinine decreases, the serum creatinine decreases in pregnancy, where our upper limit of normal, and we're talking about the micromoles that we also use in our labs or the NHLS labs, so to speak, is the upper limit is no longer 90, which is considered the normal range outside of pregnancy. 77 should be considered the upper limit of normal. Urine dipstick in pregnancy. See, Lesejo, this is how far as my AI goes, where I've tried to sort of draw this thing through these biorender app things where I got a cup of urine and a dipstick, which I thought was fancy. It is nothing compared to your introductory video. So, but I thought this was an achievement on my own. So what can you find on dipsticks still to be considered physiological in pregnancy? So one is microscopic hematuria, is usually benign. It might be due to bleeding from the small venules in the dilated collecting systems, but only benign if there is no proteinuria, because then could indicate chronic kidney disease or underlying kidney disease. If there's no infection, no renal impairment, and there is a normal renal ultrasound. I am not saying that now every time we dipstick and we see a once-off microscopic hematuria that we should be sending all these women for renal ultrasound. I'm talking sort of from a public healthcare point of view in South Africa. I do not think we have that capacity. So just keep in mind, if you see this trace of blood in the urine microscopic without any of the warning signs, that it is usually considered to be benign. Leukocytes are very common to be a very common finding on dipstick in pregnancy, probably due to the presence of a vaginal discharge, and should not be used on their own as diagnosis of UTI. Look for nitrites and especially ask the woman for symptoms of UTI, which is again can be tricky because frequently going to wee and frequency and urgency might actually be quite common in pregnancy without an infection. And then, like we said, protein excretion increases during pregnancy. So having a trace protein on a dipstick is also normal. Then one thing, and I think this is quite important, that we don't just look at our lab reports and we see if it's not in red, it is normal. The serum creatinine concentration in pregnancy is not the same as outside of pregnancy. So looking here at reproductive age women, this is a letter that was published in 2019 that shows the mean serum creatinine concentration in pregnancy. So what you see is that the mean before pregnancy hovers around about 60 micromoles per liter. Then you see that the serum creatinine from 4 weeks gestation, so basically 2 weeks post-conception, that 4 weeks into the pregnancy, the serum creatinine starts dropping. It reaches its lowest plateau between 16 and 32 weeks, where the average is about 47, then starts climbing towards term with a peak early postpartum of about, where the mean is about 67. So you see that a physiological sort of renal response in pregnancy is a drop in serum creatinine. From the same paper, you see here they've plotted the 50th, the 75th, and the 95th centile of serum creatinine found in healthy women inside and outside of pregnancy. So what you see, like we said, the blue line, the mean is about 60. The 75th centile is about 77, drops to about 58, and then climbs again postpartum. Hence, if you see a woman, you do a creatinine at any point in pregnancy, it comes back as 88. It's not in red if you're using the NHLS and the LabTrack apps, because up to 90 is normal. But when you look at these numbers here, it should already now teach you or trigger you that having a serum creatinine of 88 is most likely not normal in a pregnant woman. Another graph here, and I must thank Dr. Jared Zamperini, who's a good colleague and friend. He's one of those physicians, obstetric medicine physicians, that I truly cherish as a friend and colleague, and he might call a friend if I'm struggling with a medical problem. And he was kind enough to share some of his slides on renal disease. So this is one of those slides I borrowed, let me put it that way, from him. So all credit due there. looking at the ratio of serum creatinine in pregnant versus non-pregnant women. So if you think that the normal range for a serum creatinine is about 45 to 90. Now, if you plot this ratio in pregnant versus non-pregnant women, you see in the first trimester, that ratio is about 85%, dropping in the second trimester to about 80%, third trimester, 86%. So that is how one gets to the upper limit of normal in pregnancy shouldn't be 90. It should be 77. If you have a creatinine or a woman, your pregnant patient in pregnancy has a serum creatinine above 77, you should be worried. Good. So that by means of introduction. Now we're going on to talk a little bit about chronic kidney disease. Again, very proud of my little AI picture, nothing compared to Lesejo. I can't get over it now. I should have really asked you beforehand. Good. Talking about chronic kidney disease. So chronic kidney disease in high-income countries affects about 3% of pregnancies, estimated to be higher in our setting. It carries a major increased risk of adverse outcomes, including the risk of preeclampsia, will probably be top on every list when you talk about chronic kidney disease. Chronic kidney disease generally already characterized by hypertension and proteinuria, so there's our preeclampsia then coming in, fetal growth restriction, preterm delivery, miscarriage and stillbirth, and what's very important, especially in terms of our counseling, an accelerated loss of renal function. The staging of chronic kidney disease, generally we use the eGFR, which we don't use in pregnancy, but in an ideal world, we know the staging of chronic kidney disease in our patient. Stages 1 to 5, there's a 3A and 3B, depending on the eGFR. So a stage 1 chronic kidney disease is a patient where the eGFR is still reserved, going up to a stage 5 kidney failure or an actual kidney failure where your eGFR is less than 50. This is a very short list of potential causes. It's definitely not complete. There's a whole lot more, but these are, I think, the ones that we might encounter probably the most. You might have primary renal issues, such as your glomerulonephritis or your focal segmental glomerulosclerosis or reflux, and you might have systemic diseases such as your diabetes, autoimmune diseases that affect the whole body, including the kidney. I think one that we're going to encounter more and more, especially given our current climate, is diabetic nephropathy. GDM is on the rise, type 2 diabetes is on the rise, obesity is on the rise. So these are things, I think, especially because in our healthcare system, especially in the public healthcare system, we really struggle with diabetic control. I don't know if many of you have the same experience, but our pregnant women known with diabetes before pregnancy, the majority is very poorly controlled. So this problem of diabetic nephropathy is probably, I think, going to increase more and more over time or in the future. This is one of the graphs, again, from the obstetric medicine textbook, where it states very nicely what the effects are of pregnancy on the kidney disease and what the effects are of the kidney disease on pregnancy. So looking first at how pregnancy affects the kidney in these women with chronic kidney disease, I think what I circled in the red is your chronic kidney disease stages 4 and 5, so sort of your end-stage renal disease. You see that there's a big impact, and we'll come back to when is pregnancy contraindicated, and I think these numbers sort of explain why pregnancy is not advised in women who have a stage 4 or 5 chronic kidney disease. So you'll see that more than half will have a very small creatinine fall in pregnancy. 1 in 5 will upstage their disease or need renal replacement therapy. Their GFR reduces, and almost 9 out of 10, I would almost say almost all, loses another 25% of their GFR, and knowing that a chronic kidney disease stage 4 and 5 already doesn't have a good GFR. You have an increased loss in renal function or need for renal replacement therapy at 1 year post-delivery, which is such an impact on that renal function. And I think these are numbers that women with chronic kidney disease need to understand. Like I said, on the contrary, what is the effect of the renal disease on the pregnancy? It's also not good. Again, looking at stage 4 and 5, you have a high risk of preeclampsia, small for gestational age and IUGR. The risk of preterm delivery, nearly all women delivers before 37 weeks, with half of the babies requiring a neonatal ICU admission. So when we now want to manage this chronic kidney disease, and what we need to talk about, and I think what most of us deal with, is women through the reproductive stages of life. And I think many of us only deal with the bottom two, that antenatal and postpartum period, but we should continuously be making that link. And when I was reading about renal disease, I don't think it's a problem unique to our setting alone. I think even in the first world, that link between having a renal patient outside of pregnancy and inside or during pregnancy is sort of missing. Meaning, when you read, you see that women who are not pregnant but of a reproductive age who are currently undergoing dialysis or known dialysis patients, the majority is not on contraception, which is a problem. It means that we're not making that link. We always talk about MDT, MDT, MDT in pregnancy, which is obviously what we need, but it's like we sort of not doing the MDT part outside of pregnancy. We probably talk a little bit about contraception postpartum, but it's that preconception period, that period where someone might not be wanting to fall pregnant. In these guidelines, and I'm happy to share them. They're free on the internet, but I can share them after the talk as well for those who would be interested. It actually explains nicely that the women who are known with chronic kidney disease, the majority is not really planning to fall pregnant, but also not, having unprotected sex. They're not using contraception. So that link is something that I think, and especially in our setting, we know that the majority of pregnancies in South Africa is unplanned, that we're really still missing that link of making sure that women who are not planning to fall pregnant, all but including the ones who have medical problems, now talking about renal disease, is that those women are on contraception. So when we're in a preconceptional period, either planning or not planning to fall pregnant, what do we need to consider? So when is pregnancy not advised, right? And please be cautious. We often have a tendency to counsel patients in, if you fall pregnant, you are going to die. That is not what we want. We want to advise someone, we want to counsel, we want to give someone evidence. We should not underestimate how much our patients actually understand if we just spend enough time on trying to explain things in lay terms. If we tell a woman she's going to die if she falls pregnant, it might be true. It will chase her away and it will delay her seeking antenatal care and just worsen her outcome. So we're supposed to have, if you have that opportunity, working at a primary care clinic or in a specialist clinic, you see a reproductive age woman, is have that conversation. Are you planning on falling pregnant? Yes or no? If no, what are you using for prevention? Should you be falling pregnant? So pregnancy is not advised in stage 4 and 5 chronic kidney disease or where your serum creatinine is over 250. Women who are on renal replacement therapy, so on dialysis, are generally, the general recommendation or consensus is to recommend to wait until they have been transplanted. Again, probably a big issue. I'm not familiar with how a little bit familiar with how the transplant system in South Africa works, but I know, or I can only